My presentation takes this theme of Bauhaus, which was, an architecture and craft movement in the earliest part of the 20th century that came up with this idea that form should follow function. And that's what I'm going to emphasize in the thoughts I want to briefly share with you, is that when we think about measurement, it always has to come back to this idea of what is the function we're trying to achieve through measurement. So we know from the previous session, which I think really made it clear, that access is multidimensional and it's really complicated. And that raises a whole bunch of challenges for thinking about how to measure it in a pragmatic and operationally efficient way. And, I think we left the last session with a sense that a single measure like wait times is probably inadequate. But then you open up the possibility of dozens of other measures that could be considered, or in multiplicity. And you have the scientist perspective, and you have the veteran stakeholder perspective, and the operational people, and everybody brings a different view. And the one thing that's certain and true in all of this is that no matter what measure you propose, somebody will disagree with it and consider it essentially an access of evil, a measurement that doesn't get at the actual thrust of what you're trying to measure. So, John Fortney presented his model, which is terrific, and Lillian Gelbert had a model that also has many elements. And when you look at this, you realize, boy, there are like 30 plus different elements on John's framework, all of them important. And you could say, well, if we're really going to comprehensively measure access, we should measure all of these items, and that should be part of our assessment of how is access in the Veterans Health Administration system. And even if John sort of at the end said, well, I'm really weighting it towards the left side of the screen, and what I really care about is the actual access measures and the perceptions, you're still talking about 20 plus measures. And the challenge with that is this. I mean, how many of you who work in a healthcare setting have gotten your dashboards, your scorecards with like dozens of measures, and trying to make sense of all this and what's the real meaning in here? And I find this frustrating as a practicing doctor when I start to see dashboards from our system and scorecards, and am I supposed to focus on hypertension control today, or diabetes control, or cancer screening, or patient experience? And it's this multiplicity of measures, and even if it's just in the access domain, it becomes potentially unmanageable for really organizing how you're going to respond. And even if you do kind of a scorecard roll-up and try to do some summary measure, it still gets very, very difficult. So my approach is to step back and say, let's really ask, why are we measuring these items? How is this measure going to be used? What's its functional purpose? And then maybe that will help us really settle on what is a parsimonious set of measures that would really make sense for access. So the first functional approach to this is thinking of it, measurement as a way of doing a broad assessment of system performance. So this really is to try to answer the question, how are we doing? How is access in the Veterans Health Administration? And those are often high-level scorecards that have some key metrics, usually against some benchmark or target you're trying to achieve. The audience tends to be, the stakeholders, whether it's Congress wants a report on access, or national leadership for the VA program, or regional leadership, or veterans themselves. And in that case, you really need to have measures that are simple to understand, that have face intelligibility, that are few in number and are meaningful, and that represent important domains. So those may be things that have been mentioned, such as wait times, or new patients with a primary care visit, or here's a few other examples, and some of the patient-reported global measures. And I would also add to this that when doing overall sort of system performance measurement, I would urge that always to be done with an equity lens, where you're looking not only for the overall population, but broken down by characteristics, whether it's race, ethnicity, geography, comparing rural to urban, or other characteristics. And as I was starting to get at, one of the challenges, if you start to add too many measures on this list and are trying to display it and track it, it becomes unwieldy. Now, one approach is to try to roll these up and say we have 10 measures, and our scorecard is really saying out of those 10 measures, how many of them are at target or above. And so it's really the roll-up scores to say we're 80% of our measures are at target, and that's a little bit easier to track rather than trying to kind of track them each individually. But there's another functional use of measures, which is more at the local level, which is to help guide improvement in care. And that's really the function of answering the question, why isn't access as good as we'd like it to be, and what can we do to improve it? And the audience there tends to be different than, let's say, a report to Congress or the National VHA administration. That's really local users at the practice unit. And this is a case where actually I think you can make an argument it's good to have much more detailed granular measures that are really going to help you unpack what are the various aspects contributing to access to care, particularly in ways that is not achieving the desired performance. So for example, if you're saying, gee, we perceive from some of our more global access measure that there's a problem in access for people to get into in-person visits, then you can start measuring things like panel sizes and demand capacity mismatch, meaning, how many patients are actually empaneled with a primary care clinician? And is that a mismatch with the actual capacity of that clinician to provide care? You can look at things like unused appointment slots. Gee, we book people for 10 slots in a half-day session, and what % of those slots are never filled because of cancellations, no-show bumps? That has implications for operational management. We can look at return visits for routine chronic care follow-up. Boy, how often are people coming back for blood pressure control checks, and do they really need to come back every 2 months? Why not every 6 months? We can look at what I call repatriation rates from specialty to primary care. Gee, specialty care access is terrible. Well, why are patients with chronic heart failure who got sent for one specific question for a consultation continually to get scheduled back for every 4 month or 6 months visits with a cardiologist rather than be repatriated? So you could come up with a bunch of access measures or measures that would help you to understand access, not that you'd want to include in a report to Congress, but that would be very helpful for the managers and the teams working on how to improve access in that local setting. So let me give a case study. So there is the current survey being used in the VA, to my understanding, is the survey of healthcare experiences of patients, known as SHEP. And there's several items measuring different elements of patient-reported access. So even the surveys have many questions that get at access. And one of the questions is, well, what would be the best measure from a survey to use for this high-level measure of tracking access? And do you want to use all the measures in the patient survey or one or two of them? And you can say, well, let's answer that empirically. So Matt Augustine and colleagues at the Bronx VA did a study where they looked at which of those specific SHEP measures predicted ambulatory care sensitive hospitalization. So are there certain access that are predictive of a meaningful outcome, like an unnecessary hospitalization for deteriorating chronic care problems? And what they found was it was the only access measure on that survey that predicted it was patients' report of access to after-hour visits. Now you could say, well, does that mean that that's the only survey measure that you'd want to use to measure access? It may be important for local improvement, but I'd also question whether you want to use one study to say, we now know which is the best patient-reported outcome. I'm much more in favor, personally, of more global measures from the patient perspective. So going back a few years to Andy Beidman, who moderated the last session, and when he and I were collaborating, we did a study looking at a survey from just community residents in California about what predicted preventable hospitalizations, and it turned out a single question, overall, how difficult is it for you to get medical care when you needed it, predicted 50% of the small area of variation in ambulatory care sensitive hospitalization rates. So maybe the lesson from this is it's these global measures that are quite powerful and maybe the most meaningful to use rather than trying to deconstruct it into every measure of patient perception for telehealth visits, for urgent care, for routine chronic care, for specialty care, is to just have some much simpler global measures of access. So in conclusion, I would say it's really about the function. What is the functional goal? What do you want to use these measures? For what audience? To what end? And the final part of functionality is just the practicality. Can you come up with a simple parsimonious set of measures that are going to be reasonably simple to collect, easy to interpret and understand and communicate, that will fulfill these functional attributes of a few measures that give you a sense of overall how's our performance, and then detailed measures that can allow you to do better in some of your day-to-day operations at the local level. Thanks.